Good afternoon, respected chairpersons and distinguished members of the audience. I'm very grateful to the organizers for giving me a podium here, an opportunity to discuss with the brilliant minds of medicine and endocrinology in the sister city of Durgapur. I'm from Bardhaman. So probably I'm the one who is misfit among all the endocrinologists here, because by training I'm a hepatologist. But then in this today's world of overlapping concepts, we find that liver and diabetes, liver and endocrinology are not so far apart after all. So each of you must be seeing patients who are coming with some diagnosis of fatty liver, coming with diagnosis of liver fibrosis, or at least with the fibroscan report in the hand. So what is this concept of liver fibrosis? Why does it happen? Now, liver fibrosis, like anything, like the scarring that we learned in our Robbins pathology, is a response to injury. If you get a scar on your skin, it will end up with fibrosis, scar formation. Similarly, if you injure the liver, you injure the hepatocytes, they're going to release a lot of inflammatory signals, inflammatory molecules. They will recruit a lot of local and distant inflammatory cells. And this inflammatory milieu is going to activate these poor stellate cells which have no business and which will lie supine and lie asleep. Now, once these stellate cells get activated, they become very virulent. What do they do? They start laying down a lot of collagen fibers and other tissue material inside the liver parenchyma. And this consists mostly of collagens, fibrils, and all these. Some matrix like proteins are also laid down. And this is how a chronic hepatitis, small amount of virus in the liver, with small amount of injury or damage to the hepatocytes. The fat in our hepatocytes in itself causes inflammation. And all this have a common pathway of activating the stellate cells, whereby a fibrotic milieu is laid down in the liver. Now, how do we assess liver fibrosis? Of course, the answer is liver biopsy, right? But liver biopsy is not a homogeneous thing. So this is what it looks like in liver biopsy. What we do is called metavin stage. So this is stage 0. This is stage 1, you can see. This is the blue ones are the fibrotic tissue. This is nasal striatum stain. You can see a little more fibrosis. You can see the fibrosis is coming from one portal tract to the another. So this is called bridging fibrosis. And this is called cirrhosis, where the fibrosis is encircling or nodule at the portal tract and is causing the formation of almost a nodule here. So this is what is cirrhosis. Now, as you can see, this is very difficult for a clinician to follow and to interpret it in real life and to make decisions or make sense out of it. Only pathologists who have been specially trained in hepatopathology or GI pathology manage to make sense out of it. There was a study which was done, sorry for the animation error. So what they did was, they took this from the same patient, they took different biopsies from different lobes of the liver and found out that the readings were identical only about 1/3 of the cases. In 1/3 of the cases, even in the same patient, taking biopsies from different parts of the liver gives you different amounts of fibrosis. You have to understand that liver fibrosis is not carcinoma, it's not like pancreatic carcinoma. You take a biopsy from anywhere in the carcinoma, cancer cells. But liver fibrosis is a very chaotic event. Some of the portions of the liver, they are getting more injured, they are getting more fibrosis. Some other parts of the liver, they have got more fibrosis diffusion mechanism. So the amount of fibrosis is there, is low. So the amount of tissue that you get in liver fibrosis is very small and is not representative of the liver as a whole. So it leads to sampling errors, inter-observer variability. If you tell a patient that I need you to undergo a liver biopsy, patient says, "Oh, doctor, have I got liver cancer?" wife does not want me to get a liver biopsy, my son is in the US, he does not want me to get a liver biopsy. So there is poor acceptability of liver biopsy. And of course, even though the chances of complications are less, we do experience some amount of post-biopsy pain, some amount of bleeding in the peritoneum, very rarely perforation of gallbladder, and in very rare cases death. So liver biopsy, although we call it a gold standard, it might at best be called a flawed gold standard, not only because of the patient, but because as physicians, we are not very comfortable with interpreting liver biopsy. We want something more direct, like A1C. One value, one report, I take decisions, I can understand it, I know there are different cutoffs, and I can take decisions in my clinic based on that. So if not biopsy, then what? What do we need to assess fat? We do ultrasound. In the fibroscan machine that you all use, that you are all familiar with, there is a parameter called control attenuation parameter, which we use to assess fat. There is something called MRI-PDFF, proton-derived fat fraction. It gives very accurate values of the liver, fat content of the liver. Hepatic inflammation, to be very honest, is something we do not have good markers of. But the crux of today's presentation is assessment of fibrosis without a biopsy. I want to check how much fibrosis is in the liver, but I do not want to get a biopsy done. What are the options available to us? There are two major options. One is blood-based. So serum markers. So what do we have? We have something called APRI, AST platelet ratio index. Another is called the FIB4. These are very simple parameters. What do you need? You need ALT, AST. You have got that in your LFT report. You have the patient's age, and you have got the platelet count in your CBC value. So only 1,000 rupees of investigation will give you a FIB4 value. You can calculate the FIB4 value, you can calculate it, and it will give you some idea about the amount of fibrosis inside a patient with fatty liver and diabetes. The other thing is something called elastography. So as the name implies, what do we find out? How much elastic the liver is. Elastic measurement. How much elastic the liver is, how much stiff the liver is. By doing this, what we have here for doing this, we have got something called fibroscan. I'll come to fibroscan. We have got 2D shear wave elastography with normal ultrasound machines. And we also have got something called MR elastography. Coming back to the serum-based markers, as I was mentioning, that FIB4 can be calculated with age, ALT, AST, and platelet. What are the cutoffs? After using this formula, if you get a cutoff of less than 1.3, you can safely say that there is no significant fibrosis. And if the cutoff is more than 2.67, you think that, okay, there is a possibility that there is significant fibrosis there. Just remember these two values, less than 1.3, more than 2.67. And how do we calculate the FIB4? It's not a problem. Every one of you taking photos, every one of you has got a smartphone, right? So you put in any calculator, any calculator, and they will ask you for the age, the AST, the ALT, and the platelet count. By using this, you get these values. If it is less than 1.3, you are in the green. If it is more than 2.67, you think of therapy, you think of fibroscan, or you think of referral to a center where liver biopsies are done. And the intermediate, if there are no cardiometabolic risk factors like diabetes or elderly age, you can ignore. But if the patient is elderly, if the patient is diabetic, it is better to err on the side of caution and send the patient for further evaluation and consider the intermediate values as significant also. Now let's come to fibroscan. What do we have in a fibroscan? So, have you seen a fibroscan examination being done? How many of you have seen a fibroscan examination being done? Can you raise your hands? One. Anyone else seen a fibroscan being done? Fibroscan? Okay. So fibroscan, it looks nothing hi-fi science, it just looks like an ultrasonography probe. It looks like this. The difference is, in the ultrasound probe, you have got an array of transducers at the tip of the probe. Here you have got like a small circular or small cylindrical probe. So if you look at it like this, what it actually is that in the probe there is a mechanical actuator. What is a mechanical actuator? A It is something which gives a sharp tap on the skin or on the abdominal wall. It just gives a mechanical vibration, like this. And they have cleverly managed to put an ultrasound on the same axis. So this is coaxial. So once the mechanical actuator gives a sharp tap like this, what will happen to a tissue? If I tap like this, the shock waves from my fingers are traveling through this wood. If the fibroscan gives a sharp tap, the shock wave is going to move inside the liver. Now, anything that moves has got a measurable velocity, right? And what does the velocity of a wave depend on? It depends on the density of the medium. As you all will recall that we can hear the sound of the train engines from the rail station in the morning. And we can hear that better in the winter. Why is that? Because in winter the air is colder, the air is denser, there is more fog, and the sound carries better from a longer distance. So the velocity of sound to the carrying capacity of the wave is more if the medium is dense. So this is the exact principle of fibroscan. What happens is the mechanical actuator creates a shear wave. It travels from here to here through the liver or any tissue. And the ultrasound cleverly measures the speed of the shear wave by measuring the displacement of the tissue. So we have got the machine giving a displacement and it is measuring how far the displacement of the shear wave is moving. And by correlating it, we can find an indirect measure of the stiffness of the tissue. I'll show you what happens is, you can see here that the ultrasound probe is being placed. This is the mechanical actuator. It gives a sharp tap. You will see the shear wave starting to move. And it has a particular region of interest. This machine using ultrasound Doppler is measuring how far this wave is traveling. And it creates a strain map. How does it create a strain map? So this is the depth of the tissue cylinder, of the region of interest which I showed you. So you have, this is the starting point, this is the end point, and this is the time. And this is the shear wave, where the tissue has been displaced because of the propagating shear wave. And we know distance by time is something called velocity. So we have here distance by time. By measuring the slope of this line here, we can measure how fast the shear wave is moving. Okay, this is an animation. I'll run this for you. There are two levers. You will see two shear waves. So you have to tell me which one of these is the stiffer lever. Okay, I'll paint one second for you. Which one? That one? A or B? A or B? In which one is the waves moving faster? B. That means that tissue is denser. B tissue is denser. We all agree? And why would the liver be denser? Because of fibrosis. So you can see here that the liver on the right side is denser, it has got more fibrosis, the velocity is more, and therefore we have got the faster propagation of the shear waves. So as you can see here, if you see F0 fibrosis, F2 fibrosis and F4, as the fibrosis increases, we can see here that this slope becomes steeper. So that means that to cover the same distance, same depth, it needs, in F0 fibrosis is this much of time, in F2 fibrosis it needs lesser time, and in F4 fibrosis it needs minimum time. So the distance is the same, the time taken to cover the same distance is decreasing. That means the velocity is increasing as the amount or degree of fibrosis is increasing. So we use this, I'll come to the cutoffs and how we use these values later on. But remember, please remember that we have to be very picky and choosy in whom we advise fibroscan. 18-year-old boy going to the college or hostel for the first time, goes on a vacation with his friends to some hill station or some seaside resort, comes back with jaundice. You test for hepatitis A positive, comes hepatitis A IgA positive. Liver enzymes are 2000, 2300. Will you do fibroscan? We will not do fibroscan. Here's something else. The cellular edema is causing the liver to become stiffer. Fibroscan machine does not know that. It only finds out that the velocity is faster. It cannot distinguish from inflammation, from edema, and fibrosis. So it will give you a higher value. So 18-year-old boy with acute viral hepatitis, active liquid inflammation, active alcoholism, if you do fibroscan, it will give you a falsely elevated value. So do not do fibroscan in those settings. If there is extrahepatic biliary obstruction, you see in a basic ultrasound that the intrahepatic biliary radicals are dilated. Do not ask for a fibroscan. If there is hepatic venous congestion, cardiac failure, or renal failure patient on dialysis, be very careful, because if the liver is congested, the liver becomes stiff and soggy, and fibroscan will give you a higher value. If you have a patient with frank cirrhosis, with varices are present, ascites is present, do not ask for a fibroscan. It will give you a wrong value. In patients with ascites, please never ask for a fibroscan. What happens is, if the patient is having ascites, you give the shear wave here. Between the abdominal wall and the liver, there is presence of water. Because of this change of media, the waves are going to get diffracted. So, you are not going to get a correct velocity of the wave after all. So, in decompensated cirrhosis or non-confirmed cirrhosis, do not ask for a fibroscan. And liver stiffness values increases after food consumption, because we know that hepatic blood flow increases up to 3 to 4 hours after food consumption. A liver technique is an MR elastography. I think there are only 2 places in West Bengal which are doing MR elastography. So what you have is a passive driver like in the fibroscan machine, but it's made of plastic, obviously, because it's an MR machine. So there is conventional MR image of the liver, and this passive driver keeps on giving these impulses. And the wave is generated and it is calculated into an elastogram. The higher the stiffness is, the higher the colors will be. You've got a color bar here. So by using this, we can distinguish between the various stages of fibrosis. As you see, the higher stages of fibrosis with higher values in fibroscan, they show up differently in MR elastography than for a normal liver. You can have a lot more red here, which means that in these areas the liver is much more stiff, as found out in the MR elastography. Now, you do not need to remember this line. This is just the cutoff values. Since I am not going into MR elastography, I am just staying with liver stiffness of fibroscan. You just have to remember 2 values, 8.2 and 13.6. 8.2, something less than that, you are in the same, and more than 13.6, it probably reflects underlying cirrhosis or F4 fibrosis. So to translate all this stratification, all this physics fundas into our daily clinical practice, the current guidelines recommend that if the FIB4 score, this is the European guidelines, if the FIB4 score is more than 2.67, you refer directly to the hepatologist. If it is intermediate, you do the fibroscan or an alternative test. And ultimately, you have to manage the patient more intensively, manage the comorbidities, manage the obesity, manage the diabetes, ask the patient to take more exercise. And the Indian guidelines are also very clear that if the LSM or the fibroscan value is between 8.2 and 13.6, then you need to treat the patient with either vitamin E or with salbutamol or the newer therapies which are coming on. So to make best use of the non-invasives, we have to recognize that biomarkers are not always accurate, there are inherent fallacies. The elastographic techniques like fibroscan need to be ordered and interpreted very carefully. We really do not know how to combine the FIB4 or the other European markers, PLF markers, with our fibroscan values and get a direct or better suited pathway, treatment pathways for our patients. Maybe MR-based technologies will take over in the future, I do not know that. How the newer modalities will correlate with the newer forms of therapy, with the newer anti-diabetics, with the phenotypes. So that is something we don't know. And of course, we have to keep the cost of the diagnostic tests in mind because MR mastographies are still not available because of the inherent cost. I thank you for being so long.